Welcome to Psychiatry Grand Rounds. This morning I have the pleasure of introducing Dr. Rebecca Spivey. Dr. Spivey graduated from University of Tennessee with honors, receiving her Bachelor of Science in Biology with a concentration in biochemistry and cellular molecular biology. She also graduated from honors from Mercer University in Atlanta, Georgia with her doctorate of pharmacy, as well as a master's of business administration. She completed her pharmacy residency at Grady Health System in Atlanta, Georgia, and she is currently a clinical pharmacy specialist at James H. Quillen VA Medical Center. Please welcome Dr. Spivey.
So thank you for having me today, and thanks for the introduction. I'm a pharmacist. My title is actually academic detailer. So my job is to be a resource to providers and encourage the practice of evidence-based medicine. I'll preface my discussion today by saying that I am not a mental health pharmacist, and so anything I say, with a couple of exceptions, are based only on what's in the literature or what I've heard from subject matter experts. And so, again, a couple of exceptions, and I'll point those out. Also, I have a little cold, so I'm sorry if I sound a little manly, and I may have to drink some of this water. I'm going to try to go quickly so that we can have some time for questions at the end, but please stop me if you have any questions or if I need to slow down a little bit. Goals for the discussion today are to talk about why it's important to appropriately identify opioid use disorder, talk about the benefits of medication-assisted therapy. I'm not going to focus a lot on the drugs because if you ever become a prescriber, you're going to go through much more extensive training, so I'm just going to highlight the differences of the drug therapies, and then we're going to talk just briefly about Naloxone. I have no financial disclosures and won't be talking about anything off-label. So opioid use disorder is a chronic condition. It is a medical condition, a brain disease. We often think about opioid use disorder as being a bad decision or a series of bad decisions, as a moral failing, and we want to get away from that. We want to start thinking about OUD in terms of being a medical condition. OUD is defined by DSM-5 criteria listed here. Somebody is diagnosed with OUD with 2 or more of these things. The footnote on DSM-5 says that number 3 and number 4, tolerance and withdrawal, aren't included if somebody's taking their prescribed opioids exactly as prescribed. Because, of course, if somebody's taking prescribed opioids over a long period of time, of course they're going to have withdrawal if we take those opioids away. The thing is think about when we take, somebody takes opioids incorrectly, if they get an early refill repeatedly, then that person's not taking them like prescribed, and at that point we can include these 2 criterion. I want to point out that most of the studies that we have regarding medication-assisted therapy in patients with opioid addiction, they're primarily based on DSM-4 criteria for opioid dependence. So it's not entirely precise to extrapolate those results to DSM-5 opioid use disorder, but it's the best we have at this time. Most experts agree that that's appropriate to do. Once we look through the criteria, somebody their OUD is categorized by severity, so mild OUD, 2 to 3 symptoms. These patients may not require medication-assisted therapy, although they might still require pharmacotherapy. And if they do require pharmacotherapy, can certainly probably be managed in an office-based type setting. Moderate, severe OUD with more symptoms. So what are some things, when should we be considering whether a person should be evaluated for OUD? These are subjective things. This is not from the literature. This is pulled from subject matter expert discussions. And most of them are common sense. If somebody's coming, they know what prescribers are more likely to give them opioids. If you are seeing a patient and an opioid pain medication dominates the conversation, if the person can say what exact medication they need, what dose they need, if they are not tolerant or they're reporting allergies to everything else, maybe you bring up tapering opioids, maybe their mental health symptoms are worse in that time. A person may keep more appointments related to their pain medications, but not the other ones. Several visits within a year related to pain. If you bring up opioid safety, the patient is interested in finding a new provider, or if they're requesting opioid refills frequently. Again, these are subjective things. Fortunately, we have some studies that say, some evidence that says there are certain patients, risk factors, in patients that are on chronic long-term opioid therapy, that these patients are at higher risk of developing opioid use disorder. These patients tend to be younger. They have a current pain condition or their current chronic pain. They may have a stronger mental health history, may report insomnia, suicidal thoughts, anxiety disorders. They may have a history of illicit substance use, and may have been treated for a substance use disorder in the past. So how prevalent is this? Unless you've been living under a rock, you know that we are in the midst of an opioid epidemic. Prescription drug abuse is the fastest growing drug problem. And as we've seen significantly higher rates of opioid prescribing, we've seen increased rates of opioid overdose, but we've also seen increased rates of opioid addiction. It's estimated that the average patient that's in primary care, or that patients in primary care on long-term opioid therapy, 1 in 4 of those probably is struggling with addiction. 2014, it was estimated that 2.5 million people in the U.S. had an opioid use disorder. One study said that the lifetime prevalence of developing OUD was up to 41%. Now, this study published in 2014 looked at risk factors associated with developing OUD. And this study found that both the dose and the duration of opioid therapy were important factors in terms of developing OUD. This study, as you can see here on the left side, regardless of the dose, low dose was 36 morphine equivalents a day, medium dose was 36 to 120, high dose was 120 morphine equivalents or more per day. When used acutely, so 90 days or less, the odds ratio of developing an OUD was about 3. But when we use them longer, when patients use these opioids longer, the odds ratios were much higher. So at low dose, the odds was about 15, medium dose about 29, and at high dose, the odds ratio was 122. The average follow-up period here was a little less than 5 years. And I want to point something out here. There's a lot of barriers to addressing opioid use disorder, but I'm going to talk about one of them here. We think about the average person that has opioid use disorder as being that person that's shooting up heroin on the street, right? But we have this whole other population, patient population, that we need to be thinking about. We have these patients that have been prescribed chronic opioids for 2 years, 5 years, 15 years. They've been taking them mostly as prescribed. You know, and of course those patients are physically dependent on opioids, but there's also a group of them that have developed an opioid use disorder. And so I want you throughout this presentation to be keeping that group of patients in your mind. It's a tough conversation to have with patients because you know, they have developed this disorder as a result of something that a prescriber has been giving them, correct? You know, I think we're fortunately finally coming around to where it's an easier conversation to have because of the news. The mainstream media is pushing the opioid epidemic or is making it, discussing it, publicizing it. I think something that will help with that conversation is recognizing the changing approach to pain management and discussing that with patients. 20 years ago, we were told we aren't addressing pain enough. We were told that pain needed to be the 5th vital sign. Of course, you've heard that. That we needed to be using long-acting narcotics because they were less addictive. Now we know that that wasn't in the best interest of our patients, and opioid use disorder is one of the reasons why. It's estimated that there's a high cost associated with OUD. A 2007 analysis estimated that the total societal cost was over $55 billion. This includes workplace costs, healthcare costs, and criminal justice costs. There's also a high mortality associated with OUD. A study published in 2001 had followed a group of narcotic addicts for 33 years and looked at mortality. At 10 years, the mortality rate was 14%. By 30 years, it was almost 50%. A systematic review and meta-analysis published just this year confirmed the high rate of mortality associated with OUD. These were patients that had an OUD diagnosis over an 8-year period. A little over 2,500 patients included. Of these, 18% of these patients died. These patients that died were more likely to be male, more likely to be black. Not surprising, they were more likely to have co-occurring substance use disorders and have other physical health conditions. Also probably not surprising is the most common cause of death was drug-related, but this only accounted for about 20% of the deaths. something that was surprising, the next two most common causes of death, one was cardiovascular disease, and that accounted for about 17% of the deaths, and also cancer accounting for about 17% of the deaths. And that leads us to think that maybe there's this whole other pathological component to opioid use disorder that we're not even touching yet. So now we're going to move on to the treatment of opioid use disorder. Psychosocial interventions are often used in conjunction with medication treatment for opioid use disorder. There's an abstinence-based treatment, which is a type of non-medication approach to treatment of opioid dependence. But we have a lot of evidence that says, and I'm going to talk about some of it, that psychosocial interventions alone are not as effective as medication treatments. Opioid agonist treatment, this is Methadone, which is a full opioid receptor agonist, or Buprenorphine, which is a partial opioid receptor agonist. And these opioid agonist treatments, they work by allowing the patient to return to a productive lifestyle. The patient can engage in social interactions. They can work on those things, those problems that developed as a result of the OUD, such as impaired relationships. Opioid antagonist treatment is Naltrexone, and so it binds to the opioid receptors, but it doesn't activate the receptor. In general, when you look at recommendations or subject, if you ask subject matter experts, kind of algorithm for treatment, most people agree that opioid agonist treatment is first line. But opioid antagonist treatment does have a place. Naltrexone is particularly beneficial or would be particularly helpful in patients that are highly motivated. There are some patients that don't want to take opioid agonist therapy. Maybe it's contraindicated or it's not been discontinued. It wasn't working. There are some jobs where people can't take opioid agonist therapy. And so in those instances, Naltrexone is certainly an option. So what are the benefits to using medication-assisted therapy for OUD? I want to make an assumption here. So I'm going to make the assumption that we know now that opioid use long-term for chronic non-cancer pain is dangerous. We have a lot of evidence that says that. And we don't have a lot of evidence that says chronic opioids are particularly beneficial for chronic pain. And so we're seeing, in the midst of the opioid epidemic, we're often coming to the point of having to have the discussion with patients about tapering opioids off. And so when you're thinking about tapering patients off of opioids, some of those patients are going to have an opioid use disorder. And so what are the benefits of medication-assisted therapy in those patients? So with that in mind, if we taper opioids off in a patient with opioid use disorder, but we don't address the dependence, we are putting those patients at risk of opioid overdose. In studies looking at patients with an opioid use disorder that are tapered off, some studies estimate that the relapse rate of returning to opioid use is as high as 90%. And if you think about a patient with opioid addiction, you can discontinue the opioid therapy relatively easily. You can do it in evidence-based fashion, slowly. You can reverse the physical dependence and you can reverse the tolerance that's developed. But the underlying changes that are in the brain that have led to that patient being addicted, those changes are going to persist long after we discontinue the opioid. And so this intense drive to take the opioid still persists, but the tolerance that was protecting the person from overdose is no longer there. And so when a patient does relapse in receiving treatment for OUD, they're at a higher risk of overdose. That's why we see a high rate of overdose when patients are released from detox programs, and why we see a high rate of overdose when patients are released from prison. So having medication-assisted therapy reduces the risk of overdose in patients that are in treatment. Another barrier to treating OUD is are these protracted withdrawal symptoms, or are these the underlying pain. That's a barrier to treating patients with OUD, is the underlying pain that they report. So as we begin to take patients off of opioid therapy, you get to this point where patients say, I can't come off of it anymore. I'm having too much pain. And so, sorry, I lost my train of thought. And so with chronic substance use, we expect that when we take patients off of opioid therapy that they're going to have some acute withdrawal, but we expect that we can treat those, we can manage those, and we know that those will dissipate in a couple of weeks or few weeks. But in somebody that's been using chronic substance abuse or chronic substance use, we know that there's been molecular cellular changes in their brain that have taken place. They're having changes in behavior and in emotions. And these changes persist even after we discontinue the opioid. And so these symptoms are the protracted withdrawal symptoms. They're depression. They may present as depression, anxiety, insomnia, irritability, dysphoria. And these are all symptoms that patients with chronic pain complain of. And so you get in this situation where the patient says, I can't come off the opioid, I'm having these pain symptoms. If you give somebody medication-assisted therapy, one of these opioid agonist therapies, you're going to treat those withdrawal symptoms, and so you can better address the opioid use disorder. We have a lot of evidence that says medication-assisted therapy maintains abstinence from opioids and harmful behaviors. It keeps patients in treatment so they can continue focusing on recovery-oriented activities. We also have evidence that it decreases the cost overall. There was a 2005 analysis that looked at methadone maintenance in patients in heroin abusers, and in that study it was found that for every $1 spent on methadone treatment, there was an estimated $38 in economic benefits. I'm going to move on to some of the evidence behind opioid agonist therapy. I want to say here that there's not one really great big study. So I do anticoagulation sometimes, and what I want is a study of 10,000 patients with a beautiful benefit of one drug over the other, and we just don't have that. We do have a lot of studies, but individually the studies they all have their flaws and all have their issues. I'm going to focus just on this one methadone. I'm going to focus more heavily on buprenorphine. This Swedish methadone maintenance program is one of the landmark opioid agonist therapy trials. Even today, it's one of the most referred to trials. If you listen to 3 talks on OUD, this one will probably be mentioned twice. It was a small study. There were 34 patients, young patients. They had at least a 4-year history of IV drug abuse, primarily heroin use. These patients did methadone induction on an inpatient side. Then they were randomized to either receive methadone maintenance or no treatment. It was actually designed to be methadone versus abstinence-based therapy, but everybody that was in that group dropped out once they realized they weren't going to get medication. And so here are the results. In the methadone group, of the 17 patients at the end of 2 years, 12 of these patients were drug-free. One of the patients was in prison and 4 continued using drugs. In the control group, however, only 1 of the 17 patients was drug-free at the end of 2 years. So only 6%, and you can see that 2 were deceased, 2 were in prison, and the rest were continuing to abuse drugs. And so, not a great study, but the results are really compelling, especially when displayed in this fashion. The control group, about half of these were allowed to go into the methadone maintenance program after the fact, and this study really supports the idea that methadone protects against drug-related disease and death. Again, I'm going to go focus mostly on buprenorphine. Buprenorphine had been approved in the past, or had been used for years for pain management. It got its approval to treat opioid dependence in 2002. This is one of the studies that got its approval for this indication. This included patients that were opioid dependent. They were heroin users. This was a VA study. It was conducted over a year-long period. There were 2 phases. In the first phase, patients were randomized to receive buprenorphine naloxone or buprenorphine or placebo over 4 weeks. And then the second phase was an open-label safety phase. So the first phase was actually terminated early by recommendation of the Oversight Committee because of the overwhelming benefit of buprenorphine. At the time of termination, there were 323 patients that had started the study. 243 had completed the 4 weeks of treatment. And at the time of termination, there was no difference in the number of patients that had completed in each group. And so you can see the results here. These are opioid-negative urine drug screens at the 4-week mark. So in the buprenorphine naloxone, about 18%, buprenorphine group about 21%, and about 6% in placebo. So when you look at this, you're like, well, that's not really great. That's not a really great success. We think about those are pretty low numbers. But when you think about it relatively from a statistical standpoint, the relative risk reduction here is about 72%, and number needed to treat of 6. So when you think about it that way, it's a little more compelling. Something I'll say about all the studies that got buprenorphine approval for treating opioid dependence, they were all based on studies in heroin abusers. And now, we're talking a lot about prescription opioid users, so that is a point of discussion. They also excluded a lot of patients that in the real world we want to treat. They excluded patients that had co-occurring substance use disorders. They also excluded people that had any history of psychosis or major depressive disorder, and that's a lot of the patients that we want to treat. And this is the same study. You can see that they also looked at cravings, and that cravings decreased with buprenorphine. So this is one of the first studies that looked at outcomes in a outside the controlled environment of a clinical trial. These were opioid-dependent patients at 2 clinics in the Boston area. They were managed by 3 physicians, only one of which had addiction specialty training. These patients were self-referred, or they were referred by a practitioner. There wasn't any big outreach recruitment of patients. And these patients were followed in regular primary care visits. All patients received buprenorphine. They got up to a target dose, or an average dose of about 15 milligrams, and they were treated for 6 months. The outcome they looked at was clinician-determined sobriety. And so there were 99 patients included, and at 6 months, 54% of these were determined to be sober. When we say determined to be sober, they didn't routinely do UDSs. This was determined by the physician, by the treating physician. Looking at factors of, or predictors of success, so sober patients versus non-sober patients, I've pointed out the ones that were clinically significant. So the payer source was a driving factor. Also the length of time in treatment. So you can see that the patients that were sober, their average length of treatment was about 5.5 months versus those that weren't successful, their average time in treatment was about 2 months. So that's, I think, not surprising. Also the average age, 35 in those that achieved sobriety versus 31 that did not. I guess you could argue whether that's clinically significant. Another thing that a question that people have is, do people have to stay on this forever? And I think this is one of the biggest sources of hesitation for starting medication-assisted therapy for patients or for providers. Right now we don't have a lot of evidence that says that patients that are started on buprenorphine that they should be tapered off. But this is one of the first studies that looked at a buprenorphine taper. So these patients met DSM-4 criteria for opioid dependence. They all received induction and stabilization on buprenorphine. Then they randomized to either receive buprenorphine naloxone over 14 weeks or to receive buprenorphine naloxone for 4 weeks, then undergo a 3-week taper, and then if they were abstinent for 7 days, then they could be started on naltrexone. So it's really buprenorphine maintenance versus a taper. And so at the end of this study, the patients in the taper group, they had provided fewer drug screens, they had done fewer patient assessments, fewer patients remained in treatment. So you can see that the patients that stayed in treatment, or in the maintenance group, stayed in treatment longer. The patients in the maintenance group had a greater percentage of opioid-negative urine drug screens, so about 63% versus about 35%, so that was statistically significant. So this really supports the idea, superiority of maintenance therapy versus a buprenorphine taper. There were 2 other studies published previously, and so this study confirmed those findings. The POAT study is the largest study we have to date in prescription opioid users. So remember that when, ever since buprenorphine has really become the mainstay of pharmacotherapy for opioid use disorder, it's been based on these studies in patients that abused heroin, not prescription opioid users. We have evidence that says prescription opioid users have different characteristics than heroin users. In general, patients that abuse prescription opioids, they tend to use a lower dose in terms of morphine equivalents. They tend to have shorter treatment histories. They are less likely to use injectable drugs. They are generally have better family functioning, better social functioning. And so the thought was, well, maybe these patients that aren't injecting heroin or aren't using heroin, maybe they don't need this medication-assisted therapy. Maybe we can do less intense treatment for them. And so this POAT study was designed to answer that question. And so it's kind of complicated. It was a two-phase trial, and it was to mimic real-world practice. So the first phase was to be less intense, and so if they respond to the less intense phase, then they don't need to go through treatment anymore. But if they didn't respond, then they could go into a more intense phase. So in phase 1, patients were randomized to either receive standard medical management, so buprenorphine, or enhanced medical management. That would be buprenorphine plus this drug counseling, specified drug counseling. And in phase 1, these patients got up to their target dose within 2 weeks of buprenorphine, and then they were tapered off over the next 2 weeks. So they got 4 weeks of treatment, and then 8 weeks later, that was the follow-up for phase 1. So 8 weeks later, were they successful or not? Successful was determined to be abstinent or nearly abstinent. If they, again, if they were successful in phase 1, they were finished. If they weren't successful, they went on to phase 2. So again, they received buprenorphine or buprenorphine plus counseling. These patients received 12 weeks at a stable buprenorphine dose, and then they were tapered off over a month. And then we followed up with them 2 months later. And so you can see that the results are pretty impressive. There were 653 patients that entered the study. Remember, these patients got 4 weeks of treatment, and 2 months later, only 7% were deemed to be successful. And so that's not a great outcome. And so of those people that entered phase 1 and were not successful, 360 decided that they wanted to enter into phase 2. And so they received the same thing. You can see that while they were in treatment, about 50% of these patients were successful, meaning that they were abstinent or nearly abstinent from illicit opioids. But when we began tapering them off, at the end of that 2-month period, only 9% were successful. And so the conclusions of this study, and I'm going to present some more results, that most prescription opioid users couldn't maintain success. They couldn't be abstinent or mostly abstinent after they tapered off buprenorphine. Another interesting finding about this study is that 42% of the patients, so 42 of that 653, reported that they had pain at study entry. Of all the patients that entered this study, 83% said that they got their first opioid use from having pain at some point in the past. But 57% of those, 83%, say that they're now using opioids just to avoid withdrawal. And so that shows us that even though the pain has resolved, theoretically, that these patients are using opioids to manage their opioid use disorder. They also looked at predictors of outcome. So are there certain patient factors that determined or predicted whether a patient would be successful or not? They found that patients that were older did better, those that initially used opioids for pain, if they had never used heroin, or if they were seeking treatment for the first time, those patients tended to do better. An interesting finding was that patients with major depressive disorder had twice the odds of being successful as those that didn't have depression. The discussion behind this may be there's potential that buprenorphine has an antidepressant effect, so maybe that. It was also thought maybe these patients have higher motivation. And so at any time points, drug counseling did not impact success. And so this was kind of a downer. You know, we wanted drug counseling to be better than medication. And so they thought, well, maybe there's certain patients that drug counseling will be better for. So they thought maybe if people have more severe OUD, maybe those patients need drug counseling. So they thought if they had an addiction severity index score higher, if they had chronic pain, or if they were heroin users, they thought maybe those patients will respond better to counseling if they have counseling added, but that wasn't the case. They also thought, okay, well, you have to attend counseling to respond. And so they said adequate attendance is 60% attendance or more, and they found that that doesn't make a difference. The only significant interaction that was found is between heroin users and those that attended regularly. And so the takeaway there, if there is one, is that heroin users, if they attend drug counseling, can have outcomes comparable to those people that have never used heroin. We also found that the early response to buprenorphine is important. So they calculated this positive predictive value and a negative predictive value. And we see the graph on the left-hand side that if a person used, or that somebody that abused opioids during the first week of buprenorphine treatment, their positive predictive value was only 49%, and this is that they would be abstinent at weeks 9 through 12. It went up to about 56% if they used during weeks 1 and 2, but pretty much stabilized after that. If you look at the negative predictive value, it's pretty impressive. So if somebody abused opioids during week 1 of therapy, their negative predictive value was 80%. Went up to 94% if they used during weeks 1 and 2. So that means that the likelihood of somebody being abstinent at weeks 9 and 12, if they are abusing opioids during weeks 1 and 2, is only about 6%. And so this wasn't done in this study, but the discussion about these results was, well, maybe, maybe we need to focus more intense counseling early on. Maybe that would push these numbers in the right direction, and we could ensure better treatment or more successful treatment. Another thought is, well, maybe if these patients don't respond early to buprenorphine, maybe we stop treatment then and reassess the plan. Maybe we give them methadone or Naltrexone. I do briefly want to mention this Cochrane review that was published last year. This included studies published from 2003 to 2015, and they had to be randomized controlled trials, and we only got 6 that met inclusion criteria. This Cochrane review attempted to answer the question, which is better, methadone or buprenorphine? They found 3 studies that could be included in this evaluation. And what the authors of this review found was that there was no difference in the mean number of days of opioid use, no statistical difference in opioid use as determined by UDS or by self-report. This was similar to what was found in a 2003 Cochrane review that attempted to answer the same question. In that Cochrane review, what they found is that methadone was better at keeping patients in treatment, had better treatment retention, but that if buprenorphine and methadone are used in high-dose, flexible dose regimens, that they can reduce opioid use to the same extent. This Cochrane review also attempted to answer the question, in a patient that has opioid use disorder, can we just taper them off safely, or do we need to give them buprenorphine? And so that was another question. What the authors found is that there was no difference in the mean days of opioid use either in the last week or the last month, but that when these patients were given buprenorphine, that buprenorphine was associated with reduced opioid use as determined by UDS, by self-report, and that these patients stayed in treatment longer. So we've talked a lot about the opioid agonist therapy, reducing cravings, preventing withdrawal, decreasing opioid use. We didn't talk about, but there is evidence that opioid agonist therapy reduces criminal behavior. But what effect on mortality does opioid agonist therapy have? This study just came out this year, this systematic review. This included 19 cohort studies, and to be included in this review, studies had to address all-cause mortality or overdose mortality. Of the 19 studies, there were 18 methadone cohorts and 3 buprenorphine cohorts. And so this is a busy slide, so I'm just going to highlight what I want you to look at. This is all-cause mortality. The solid boxes on the left side, those are that's mortality in treatment. The white boxes on the right-hand side, those are mortality outside of treatment. And you can see that mortality is higher in almost all cases when patients are out of treatment. The top ones here are methadone and the bottom ones are buprenorphine. And I've highlighted in the red boxes the pooled mortality rates of methadone and buprenorphine. You can see that the pooled mortality rates for both of those, there's a difference. In both of those, of course, the mortality out of treatment is higher than that in treatment. The timing of mortality changes was interesting. So, it stabilized when patients were on treatment, but when patients got out of treatment, there was a rapid or a significant increase in mortality in the first 2 weeks out of treatment for the methadone patients, and a significant increase in mortality the first 4 weeks out of treatment in the buprenorphine group, which again, that reinforces the idea that when patients come out of treatment, first out of treatment, that are really high risk of death, particularly overdose death. And you can see in general that the mortality associated with buprenorphine is lower than that for methadone, and that's consistent with its safety profile. All right, so I want to move on to talking about Naltrexone. We probably underuse Naltrexone for opioid use disorder. We use it a lot for alcohol use disorder, but there is some evidence that that it is helpful. And again, like I said earlier, there are certain patients that especially would benefit from naltrexone. This study was published in 2005. It included patients from 13 sites in Russia. All of these patients had undergone inpatient detox. Something to remember about naltrexone is that it's going to induce opioid withdrawal, so they have to be abstinent from opioids. They have to have all opioid out of their system. They were randomized to receive long-acting naltrexone Q month or placebo every month over a 24-week period. They also did counseling. So there were 250 patients included here, and those that had a good clinical response in the long-acting naltrexone group is about 52% versus in the placebo group about 32%. Kind of like with the opioid agonist therapy, you look at these numbers and you're like, I'm not sure that's a great outcomes, but relative risk reduction is 38%. Number needed to treat here is 5. So when you look at it from that statistical perspective, you can see the benefit of naltrexone. One thing that this study looked at was they thought, well, maybe patients with less severe OUD, maybe those patients will be the ones that would respond better to naltrexone. But the study actually found that regardless of severity, even those patients that had higher severity, even those patients responded to naltrexone. And so that was a promising finding of this study. One study that just came out that's really exciting, it just came out in the last few weeks, this was one of the first studies that looked at long-acting naltrexone versus buprenorphine. So is long-acting naltrexone as effective as buprenorphine in reducing opioid use? And so these patients, this was a study in Norway. They received daily buprenorphine or once monthly naltrexone over a period of 12 weeks. And you can see that the patients in the long-acting naltrexone group, that they fared pretty well compared to the buprenorphine group. This is actually a non-inferiority study, but the naltrexone group actually, in terms of retention, did pretty well. This is a busy slide again, but to look at it from the bird's eye view to get the overall picture. The blue line is buprenorphine, and the orange line is naltrexone. And these are all graphs of days of drug use, and so different substances. So if you look at this one up here on the left-hand side, this is heroin use. And so a promising finding of this study is that patients that were randomized to the naltrexone group at all time points had significantly less heroin use than those in the buprenorphine group. You can see it's mostly not significant throughout the rest. Another interesting finding of this study is that the patients in the naltrexone group reported greater satisfaction. So this is a visual analog scale, patient satisfaction, 0 to 10, of course. And those patients in the buprenorphine group reported significantly lower satisfaction with their treatment versus those in the naltrexone group. So I've talked a little bit about counseling and that the evidence isn't really supportive. Cognitive behavioral therapy, is a unique type of psychosocial intervention and used in other mental health conditions, of course, and substance use disorders. And the unique feature about it is that it has prolonged efficacy past the point of treatment, the so-called sleeper effect. And so this study was done to see, does cognitive behavioral therapy, when added to buprenorphine, does it help patients? So this is opioid-dependent patients. Over a 3-year period, everybody received buprenorphine induction, stabilization, and then they were randomized to receive physician management, so buprenorphine, or physician management and cognitive behavioral therapy. They received, it was a 24-week trial, so everybody got buprenorphine for all 24 weeks. The CBT group just got CBT for the first 12 weeks, and so the idea was to see 12 weeks after treatment ends, is it beneficial? Or is it still showing benefit? And unfortunately, we didn't find that. This study said that even when we add CBT to buprenorphine, we're not seeing great outcomes in terms of opioid use. There was one 1993 study that showed that when counseling was added to methadone maintenance, that opioid negative UDSs, or the percentage increased, so they actually used less opioids. But most of the studies we have are not really in support of psychosocial interventions, or they're not, they don't show that they improve outcomes. Until the POAT study, we had no studies looking at counseling in prescription opioid users. with all that in mind, when you talk to subject matter experts or practitioners, all still agree that counseling or recovery-oriented activities, non-pharmacologic things, need to be in place. That's a vital component to appropriate management. And you can see here, this is retention and treatment. You can see that not a big difference between the two groups. Just briefly, I'm going to hit on the drugs and point out the differences. So methadone is available as an oral concentrate, an oral solution, and tablet. There is an injectable, but remember we don't use that when we're talking about opioid dependence or opioid use disorder. My understanding is that in opioid treatment programs, they're generally dispensed as one of these colored liquid forms, and that the degree of color never changes for the psychological impact of the color changing. Methadone, remember, is a full opioid agonist. It blocks the effects of other opioids, reduces cravings, relieves symptoms associated with withdrawal. Methadone has a really long half-life and it's excreted slowly, and so that works in our benefit in terms of dosing daily for opioid dependence. But you have to be careful with the dose titration, especially in patients with any kind of renal impairment. You have to titrate slowly because of the risk of accumulation and increased risk of adverse events, specifically respiratory depression. When we're talking about opioid use disorder, remember it's administered daily. If you see it administered more frequently than that, they're probably using it for pain, not opioid use disorder. Methadone can only be dispensed, when it's used for opioid use disorder, can only be dispensed through a federally approved opioid treatment program, and of course that's a barrier to getting methadone to patients. Suboxone comes in a number of formulations, a buccal formulation, a sublingual formulation, transmucosal products. Remember that it's a partial mu opioid receptor agonist. It does have a high affinity for that mu receptor, and it slowly dissociates, and so that allows for once daily dosing, again, which is helpful when we're treating opioid use disorder. There are some experts that will say you can administer buprenorphine twice daily in patients that you're treating for opioid use disorder, and that helps with the underlying pain. That's a little bit controversial. In most cases, we see it administered once daily. Buprenorphine is safer than methadone, and so that's a good thing, of course. Most of the time when we're using buprenorphine for treating opioid use disorder, it's administered in combination with naloxone, and so these are formulated in a 4-to-1 ratio. Remember that when you take, naloxone has no oral bioavailability, so if taken orally it's not going to do anything. But if the product were ever manipulated for injection, that it would counteract the buprenorphine component, so it's basically an abuse deterrent. Prescribers do have to get an X waiver to prescribe buprenorphine. It requires an 8-hour online course. You can do it an hour at a time now, so they've made it as easy as they can, and buprenorphine can be prescribed or dispensed from any pharmacy. Naltrexone, when we're talking about long-acting naltrexone, we're talking about Vivitrol, the injectable formulation. So it's an intramuscular formulation. There's also oral tablets. Most of the data for opioid use disorder, opioid dependence, is with the long-acting formulation. Remember that it's an opioid antagonist, and so if other opioids are bound to that receptor and you give naltrexone, naltrexone has a stronger affinity for that receptor, so it's going to kick those other opioids off, and it's going to induce a very strong or intense withdrawal. So you have to make sure patients don't have any opioids in their system. If there's any question, there's a naloxone challenge test that you can do, or that the prescriber can do. It can be ordered by any prescriber, so there's no abuse potential. It's not a scheduled substance, but it should be administered by a healthcare provider. It can't be taken at home. All right, so I think I have 10 minutes or 5 minutes. I'm going to get through some of these other things. We know that substance use disorders are highly stigmatized compared to other chronic conditions, and that this is one of the barriers to addressing opioid use disorder. There are entire studies devoted to seeing what means are effective at reducing the stigma associated with opioid use disorder. What's not beneficial is educational pamphlets and waiting rooms. Also not beneficial is broad education to healthcare providers, which the irony is not lost on me that I'm talking about this now. What is effective is testimonials, so patients giving their personal stories on how they had opioid use disorder and how they're overcoming it. Another thing that's beneficial is exposing trainees, so medical residents and medical students, making sure that those trainees have interaction and exposure to patients with substance use disorders. A first step in destigmatizing is just watching the language you use. So making sure that we're using more positive language, no derogatory or accusatory language. This is one of my favorite things that I found or have seen while I've been doing all the reading on opioid use disorder or medication-assisted therapy. This was published in 2000 in a JAMA article. And it says, what if we treated hypertension like we do addiction? So these patients would be admitted to a 28-day program. They would receive counseling on lifestyle, diet, exercise. Most patients would not get medications. Patients that did complete the program, they would be discharged to community resources. They usually wouldn't see a doctor after that. And when we evaluated these patients 6 or 12 months later, they would only be counted as considered a success if they had had a normal blood pressure through that entire period. So when we're talking about something like hypertension, that sounds so ridiculous. And so it really shows how far we need to come in terms of our thinking about substance use disorders. One thing is, and kind of to segue into this next section, we don't need to stop treatment because somebody has a relapse. We expect relapses. We know that opioid use disorder is a chronic condition, that there's periods of remission and relapse. Maybe treatment needs to be reinstated or adjusted or changed. We want to avoid medications that have potential for interaction, so certainly opioids, other things like benzodiazepines, Z-drugs like Zolpidem, and then muscle relaxants is a big one. Also, we talked about earlier how patients with opioid or with mental health disorders are at a higher risk of developing an opioid use disorder. And so as we begin to address the opioid use disorder, we want to make sure that we're addressing the other psychiatric conditions as well. We've talked a lot about the role of counseling, but we do want to encourage participation in non-pharmacologic and cognitive behavioral therapies. So encouraging patients to attend things like Narcotics Anonymous, encouraging participation in other support groups, and really embracing, if they are experiencing pain, embracing more active self-management approaches. And then finally, we want to make sure that these patients have access to Naloxone. So I'm sure that I hope that this group has been received some education on Naloxone in the past. We generally think about giving Naloxone to patients that are prescribed chronic opioid therapy or we know are using chronic opioid therapy. And there's a misconception that if we're taking opioids away from somebody safely, albeit, that they don't need Naloxone. But remember, we've already said that patients that are being treated for opioid use disorder are at a high risk of overdose. And so we want to make sure, or a high risk of relapse, and with the high risk of relapse, the high risk of overdose. And so this is an opportunity to educate patients on how to prevent an overdose, how to recognize an overdose, and how to respond to it. So Naloxone is available as an IM device, also as an intranasal device. You can get it from, or patients, caregivers can get it from local pharmacies now. Just briefly, I've inserted the VA-DOD guidelines that were published in 2015, and these are for the treatment of substance use disorders. I've just pulled out the pharmacotherapy portion for opioid use disorder, and this really supports what we've talked about. So if you look at recommendation 8, it says that we have high-quality evidence from multiple randomized controlled trials and meta-analyses that medication-assisted therapy with buprenorphine or methadone improves outcomes for opioid use disorder. If you look at recommendation 11, if opioid agonist therapy isn't available or if it's contraindicated or if it's been discontinued, then long-acting naltrexone is a reasonable option. And then if you look at recommendation 13, as we're treating patients with opioid agonist therapy, specifically buprenorphine in the office-based setting, we need to make sure that these patients have access to some kind of psychosocial intervention or drug counseling. And then finally, just some recent things that have happened in the last year or kind of in the pipeline. Offering medication-assisted therapy within the primary care clinic has been studied for years, but we're really not seeing it in practice. And so legislation and there is support for trying to get primary care providers to prescribe buprenorphine. The argument in favor of this is that the team-based approach to chronic disease state management is already in place, and so opioid use disorder is just another thing, just another chronic condition to include. Some patients don't want to go to a substance use disorder program. They feel comfortable going to a primary care clinic. There's no stigma associated with that. Also initiating medication-assisted therapy in emergency departments. So within the last couple of years, there have been a few studies that have favorable outcomes. I don't think we're seeing that anywhere around here, at least happening yet, but that maybe when the patient's presenting in a state at the emergency room, that maybe that's the opportune time to discuss addressing the OUD with pharmacotherapy. There's also a once monthly buprenorphine product that is pending FDA approval, and so that is in the pipeline. There was also this FDA drug safety communication that came out in September. Traditionally, we think about opioids and benzodiazepines not being used in combination. And the general consensus, at least on a national level, is that if somebody's on benzodiazepines, they're not a candidate for opioid agonist therapy. This drug safety communication came out and said, we know it's a risky combination, try to avoid it if you can, but if somebody's on a benzodiazepine, it shouldn't hinder them receiving medication-assisted therapy. The Comprehensive Addiction and Recovery Act was passed into law in 2016, and this is basically a coordinated response to the opioid epidemic. It involves a number of components: prevention of drug abuse or addressing the opioid epidemic in terms of treatment and of recovery, criminal justice reform. And so a large part of this is dedicated to expanding access to treatment for opioid use disorder. And then finally, we know that we have the Opioid Commission appointed by the President just this year. They came out with a report in July of 2017, and then we know that the President declared the drug epidemic a public health emergency, I think just last week. So we'll see what comes of that. All right, I finished on time. Some resources if you're interested. The SAMHSA website is great. It has a lot of resources that you can order. A lot of them are free, or you can print them out. It also has, as part of SAMHSA, is the pcssmat.org. That's where you can get training, and again, it's free, and you can do an hour at a time at your convenience. Even if you don't have any interest in becoming a buprenorphine prescriber, it has a lot of great information in terms of just having a better understanding about this and educating patients about medication-assisted therapy. All right, what questions do you have? Yeah.
I had a question about the cost of medication-assisted therapy and if that's a barrier to treatment.
What about the cost associated with it? So a lot of the clinics around here locally are cash only, and so that is a barrier for sure. It's a barrier we run into at the VA because we can't send patients out because we can't send them with cash, of course, to pay. There was an act passed in 2008 that required health insurers to treat substance use disorders and mental health disorders like any other chronic condition. They couldn't have really high copays or anything like that. But there was a task force that came out. It was appointed under, I guess, President Obama. They released a report in 2016 that said there are still restrictions in place that hinder access. So the example that I saw was that really stringent prior authorizations for treatment. And so, of course, if it's too stringent, then they can't get treatment. Yes?
So I went to a talk yesterday at Northeast, I think, State had a similar talk, and they had a few individuals there that were going through the process of detoxing as well. And going along the lines of what Dr. Zazi was talking about, how much does it cost for each of these individual drugs? Because obviously getting cash payment is challenging, but the patients that were there were saying that, they had like a $400 heroin addiction that they were dealing with. And sometimes they had to sell part of their medications in terms of, with Suboxone in order to afford it.
So I guess I can't speak to that for sure. I'm not exactly like what patients pay in a cash clinic. But yes, I'm sorry, I can't answer that.
That's fine. Do you know, I'm sorry. I actually spoke with one of the insurers that was there, and they said that there is coverage generally for some of these. Is it a rehab program that they typically do? If you're part of that, is that generally covered, do you know? Or
yeah,
no?
so they are supposed to cover it, I guess, and I'm not speaking about specific plans, but what this one study found was that even though they are supposed to cover it, that there are still barriers to coverage. Just, if you think about like a surgery, for instance, it should be covered, but sometimes for whatever reason, there's caveats in there that can preclude a patient getting surgery, for instance. So I think it's the same kind of thing.
So one of the concerns that I've seen, or one of the things I run into, and I know many of my colleagues run into here too, is that we often as psychiatrists get referrals from pain management clinics or folks maybe who are giving these kinds of Suboxone or whatever, but many times they're on opiates with benzos. And then they, of course, know that that's not indicated to
Right.
mix. So then they want to send them to a psychiatrist to say, go see a psychiatrist, see if they'll approve your benzo or they'll continue that together.
Mhm.
So do you have a sense of why that's happening so much with these folks that they are choosing to have them in both of them? I mean, besides the fact that patients like it and whatever, enhancement or whatever, because that's a major problem.
Yeah, so I should say that I have, no experience about this or clinical experience. What I will give my answer is based on my discussions with mental health and primary care providers that I interact with. I would say that that's a multifaceted answer. For one, I would say that we're dealing with a tough patient population, and sometimes it's just whatever you can get to move on to the next thing. And I don't mean that we're dumping patients or anything like that. It's truly trying to get on to the next thing. I think also from whoever's prescribing the buprenorphine, having another practitioner validate that decision maybe to come off of the benzodiazepine, that's really reassuring. And we see that a lot at the VA dealing with opioid safety, for instance. Having one provider tell them that opioids is dangerous, that's not as effective as having their primary care provider tell them that, their mental health provider telling them that, their social worker. And so, I guess the more optimistic answer is that we're looking for validation that that's not a safe combination. So yeah, I know it's a particularly challenging thing. Did you have something to add? Oh, okay. You had a
Hi.
question.
I had a question about the relapse rates after being given the medication therapy. I know you touched on it a little bit, but can you tell me how it is in the long term as far as relapse and
So we don't, yeah, so the question was, what about long-term relapse when we, after stopping treatment? And unfortunately, we don't have great data there. We don't, what we want is a study, what we want is a study where patients have been on buprenorphine for a year or 2 years, and then they come off. How did those patients do? And right now, we don't have that data.
So one of the things I was going to ask you to do, I noticed that Dr. Rose is here, and you and she and I, of course, sit on the VA Opiate Safety Initiative. One of the concerns we have had is trying to determine what low-dose opioid therapy is in pain patients that need maintenance. It's very interesting that you bring up how this tends to blend harm reduction versus abstinence as a choice. Those are the two major competing theories of what to do about opiate use. And I wonder if you might just mention to everybody a little of the dilemma we've had about deciding what does constitute low-dose continuing therapy.
Yeah, so we have the Opioid Safety Initiative was established in 2015 at the VA. It's a national initiative to basically make sure we're using opioids safely. So what we've been doing at Mountain Home is we have asked primary care providers, who are the largest prescribers of chronic opioid therapy for chronic non-cancer pain, to look at every patient that is on chronic opioid therapy and make the decision, are the benefits of opioid therapy in this patient, do they really outweigh the risks? And what we're finding is in most patients, that's not the case. In most patients, it is in the patient's best interest to come off of opioid therapy. So what Dr. Hendrick is talking about is, we started looking at the highest risk patients. So we started looking at those that were on combination opioid benzotherapy or those that are on higher doses. And so, those patients we could address pretty regularly. People accept that. Providers accept that, okay, maybe patients don't need to be on 150 morphine equivalents a day. What we're running into now, we've pushed the doses down, and we have patients much safer. I think we all feel better and sleep a little better at night knowing that these patients are safer. But now that they're on lower doses, what are we going to do with these? Should we try to get these patients off of opioid therapy totally? Or, are there some patients, and we mostly tend to think that there are some patients where it's okay for them to be on low-dose PRN opioid medication. But deciding what that low dose is an arbitrary number, and we all have different opinions about it, and our opinions are largely based on the interactions that we have with patients and providers. So yeah, that's the dilemma that we're in. What is that low dose? What is that arbitrary number?
I was wondering if you would say that you know more about separating opioid use disorder patients who have primary recreational use versus those associated with chronic pain. I think there are two really different types of groups, and I don't think you can identify them by those who've ever injected heroin, because now with the crunch on prescribing, we have more patients with chronic pain injecting heroin.
Sure, sure. So talking about how the differences between people that are using chronic opioid therapy for pain versus those that are just using it recreationally. Again, the POAT study attempted to answer that, but there were some flaws in that study, and it didn't give us the answer we wanted. We wanted that people that were using it, prescription opioid use, that they could be managed with counseling or they could be tapered off of therapy. And so I think we're still in pursuit of that answer that we're looking for. But we do know that there's different characteristics between the different groups of patients. Yes, right. Right, but when we looked at those patients, only about half of them were still reporting pain. So, yeah.
Just want to thank you for doing such a wonderful presentation of going through major studies and covering it in evidence-based way. It was really, really helpful. The question I have about the study in Russia you talked about with Naltrexone, that population, was it prescription drug abuse related subgroup, or is it was that a group
which study are you talking about?
The study that was done in Russia for Naltrexone.
This one, yes. And
yes.
so what was your question?
So the patient population was, this is prescription...
oh, yes. So these were mostly heroin users.
Mostly heroin users, okay.
Yes. Almost
Despite
all.
that, there was a
Yes.
good data on that.
Yes, yes, I'm sorry.
Was there any data about the mortality with Naltrexone? Because we think probably there is some protection with Naltrexone long-term treatment in terms of the risk of overdose and dying from opioid overdosing.
So if there was, I'm sure there probably was mortality data, but I can't recall off the top of my head what it was. And so you're saying that the risk of overdose in somebody that's on Naltrexone, is that what you're talking about?
Right. It probably, theoretically, probably is lesser.
So it would be theoretically less if the patient maintained in therapy, of course.
Right.
But just like with anything, if the patient stops opioid therapy for a given period of time, their tolerance is going to be reduced. So if they start taking after that, they are at risk of overdose. Especially, and that's the downside of oral naltrexone, is that patients have to take it every day.
Right.
But with the long-acting, it should last for a month. In theory, it lasts for a month and protects them for a month. So as long as they keep those appointments.
That's what I was thinking. Has any study looked at it? Because, I mean, that's technically, the worst come scenario is death, right? I mean,
yes. So you're saying, is there any study that's looked at
IM naltrexone versus Buprenorphine, and look at risk
well, so
of overdosing?
this one here is the one of the first ones or the biggest ones, and this is a really this was exciting when it came out, and it just came out recently. So this was I don't think anybody died in this study. It was a pretty short study. I don't think anybody died in this. Mm-hmm.
Okay.
Yeah.
Thanks. I agree. A great presentation, but I have to tell you that I'm left quite confused as a pharmacologist, because what you show is that, and it's not you, but I mean the data show that behavioral therapy is essentially ineffective, and that a full agonist, a partial agonist, and an antagonist are essentially equally effective. So that leaves me at a loss for understanding why the behavioral therapy and interventions
I think
are not effective.
Yeah,
Something has to account for how an agonist and antagonist can give you the same results.
You're right about that. You're right, and I think that the antagonist, the idea is that even if they do abuse drugs, as long as they keep coming for that monthly appointment, that even if they take opioids, it's not going to have the effect, right? That it's that's why the antagonist works, is that it reinforces abstinence. But I think that everybody feels that way. I mean I think that's why people are so hesitant to start medication-assisted therapy, is we just don't have great data This is not great data, and we want counseling to be better. We want psychosocial interventions to be better, or at least we want them to show a benefit. But yeah, I mean, yes, you make a perfectly great argument. That, yeah. So.
We're a little over time, and I'm afraid I'm kind of opening a can of worms, but I'm going to respond to Greg's inquiry. It's an interesting question. What is the operative feature that makes that the case? Mm-hmm. And one of the things I'm going to point out is that psychologically and from a defense mechanism's point of view, for these patients, they're typically trying to achieve a dissociated state. And no matter which end of the receptor you may be stimulating or failing to stimulate, in the end, all of these things do something to allow them to be able to maintain their psychological status without such a need for dissociation. Mm-hmm. So I think the underlying factor that kind of bridges the question pharmacologically has to do with the nature of the psychological lives of individuals that are impacted by these particular substance use disorders, and the fact that in so many ways they're really chasing a dissociated state as opposed to, say, pain relief. For instance, one of the pieces of data, as I recall, the Naltrexone versus Buprenorphine, amphetamine use goes up quite a bit. If you block the ability to get any kind of opiate stimulation, but then you can use amphetamine, well, all of a sudden you find your way into a new dissociated state. Sure. So part of it has to do that it's not just the pharmacology of it, it's also the psychological structure of the individuals involved.
Thank you, Dr. Spivey.
Thank you all.